Hello, everyone. My name is Vinicio de Jesus Perez. I'm an associate professor in pulmonary medicine at Stanford University and staff physician of the Adult Pulmonary Hypertension Clinic. Today, I would like to talk to you about ongoing clinical studies in pulmonary hypertension and what that means for practitioners and patients with pulmonary hypertension. The year 2020 is upon us, and there is a lot of activity within the field of pulmonary hypertension research. Many patients have come to us to ask about the implantable pumps or the new subcutaneous pumps that are being planned by United Therapeutics. It is important to point out that the implantable pump has now been approved, and there are selected centers in the United States that are actually doing this. These are very appealing because patients will no longer have to deal with carrying the pump, mixing the medication, or being concerned about line infections or disconnections. The implantable pump promises to take the pump and tube system under the skin so that the risk of infections will be significantly lower compared to having a tunnel catheter. This is actually a really exciting initiative. Now, what the patient must be aware is that this will require a surgical implantation, which can be risky for some patients due to the state of their heart failure. This is something that, however, it can be considered in patients who are clinically stable and who the clinician is willing to evaluate and considers to be a good candidate. On the other hand, United Therapeutics seems to be working on a new version of a subcutaneous pump. It's something that looks like a disc, which can be applied to the skin with pre-filled cassettes that will then allow the patient more freedom to move around and be less conscientious about carrying a pump that will be visible. This will be more discreet. It doesn't require any surgical implantation and seems to promise that patients will be able to continue with the medication. To the best of my knowledge, this is not approved. It's still under study, but it's something to look forward to in the very near future. Now, on to what the field is working right now, which promises to deliver some results in the next couple of years. What the field is working right now is on disease-modifying therapies. This is a term essentially that entails multiple things, but in my mind, when I talk about disease-modifying therapies, I am talking about medications that do not only act as vasodilators. Rather, they are targeting the fundamental processes that drive the cellular growth and accumulation that ultimately leads to vessel obstruction and pulmonary hypertension. There are several trials that are currently ongoing, which are tackling several targets that are of interest in pulmonary hypertension. Currently, there's a compound called sotatercept, which is an activin inhibitor. This is a pathway that appears to be active, particularly in patients who actually have deficiencies in the BMPR2 signaling pathway, which is the most common cause of genetic hereditary pulmonary hypertension. This is a drug that is injected, but it has the potential of offsetting the adverse effects of activin by inhibiting the ligands that trigger the signaling downstream of the activin receptors, while promoting the salutary activity of the BMP signaling pathway. This is really exciting. This trial, the phase 2 study, has completed recruitment, and we expect to hear preliminary results earlier this year. On another note, there is the Phantom study, which is using anastrozole, an aromatase inhibitor currently in use for breast cancer, as treatment of pulmonary hypertension. The rationale for this is that, as many of you know, pulmonary hypertension is a female predominant disease. For many years, we have been trying to elucidate how estrogen plays a role in either promoting or protecting against the disease. It is a real controversial topic amongst researchers, to the point that we talk about an estrogen paradox in pulmonary hypertension. Nevertheless, following preliminary data that shows that anastrozole is safe and could have potential benefits in increasing functional status in patients with a pulmonary arterial hypertension, this is an NIH-sponsored study that is currently ongoing and promises to answer whether targeting the estrogen signaling pathway may be a novel therapeutic approach. The other interesting target is that of metabolic dysregulation in pulmonary hypertension. This is a really interesting topic, and we've been really interested in this over the last 5 to 10 years, since it was identified by Dr. Evangelos Mikalakis, Dr. Steve Archer, and Dr. Seb Bonet, in which there is evidence that, just like in cancer, there is a switch of pulmonary cells to use glucose to generate the energy they need to grow and proliferate. Now, the idea is that if you can actually increase oxygen consumption and try to reestablish the metabolic balance within the cells, you can potentially shut down this exaggerated growth that we see in the vessels of pulmonary hypertension patients. As part of this, there's an ongoing study using metformin as an agent that does just that. Now, metformin is an agent that's already in use for the treatment of diabetes and other complications of metabolic syndrome, which is, of course, the syndrome associated with obesity, diabetes, high lipids. So, to repurpose this drug as a therapy for pulmonary hypertension is very appealing, given how our group and others have identified that insulin resistance plays a role both as a risk factor and as a agent that compounds the complications of pulmonary hypertension. I think last in the list of hot ongoing trials is a trial currently using stem cells in pulmonary hypertension. When we think of stem cells, we are talking about a wide range of different cell types. What the group in Canada, led by Dr. Duncan Stewart, is doing is that they're taking cells called endothelial progenitor cells. These are cells that can be differentiated into endothelial cells, and the idea is that these cells are circulating in the bloodstream, and when there is blood vessel injury, they actually go to those areas and become endothelial cells, thus helping regenerate the lost vessels and reestablishing the balance. Dr. Stewart has developed a technique in which he can harvest these endothelial progenitor cells, and he can actually genetically modify them to carry a gene that produces nitric oxide. And this is critical because, as you all know, the targeting of nitric oxide is a huge deal in pulmonary hypertension. This is where riociguat and sildenafil in particular work. So the idea is that by engineering these cells and giving them back to the patient, we can actually rescue lost vessels in the lungs. And that will hopefully provide the patient with better blood supply, or at least halt disease progression. So this is an ongoing trial right now. It's called the Sapphire study. It promises to really open up the field. Last but not least is an ongoing study that will start to recruit very soon, which has to do with the use of elephant for the treatment of pulmonary hypertension. The idea behind elephant is that the extracellular matrix, which is where the cells in the blood vessel wall are housed in, is altered in pulmonary hypertension. And as a result of this, there's a release of growth factors that alter the growth properties of the cells. Dr. Marlene Rabinovich has been a pioneer in this field, and she has identified an enzyme called elastase, which plays a critical role in this process. Elephant is an inhibitor of elastase, and its capacity to inhibit elastase and preserve the extracellular matrix, resulting in a normalization of cell behavior in pulmonary vessels, has been shown in multiple preclinical studies. Currently, the NIH has approved funding to support the first clinical trial on elephant in pulmonary hypertension, which will start to recruit pretty soon. At this point in time, we're living in a very exciting time for pulmonary hypertension. Lots of ongoing clinical trials for patients. The most immediate payday for these trials is going to be the release of the sotatercept preliminary results earlier this year, as well as being able to see more of the implantable pumps being available. So lots of items to look forward to in the near future, but rest assured, the field is actively working to identify cures for pulmonary hypertension. I would like to encourage physicians and patients to consider enrolling in clinical trials at their local pulmonary hypertension center, since we depend on the patients to be able to help us carry out these studies in a timely manner. We cannot do this alone. We want to see patients partnering with us so we can move the field forward. My name is Vinicio de Jesus Perez, and I am aware that I'm rare.